So the EHR incentive programs obviously put in place to encourage people to use electronic health records in a meaningful way. This is the concept of meaningful use that will impact healthcare outcomes, patient safety, and ultimately the idea is to reduce costs within the healthcare system. And there are incentive payments that are available for folks who are using certified electronic health records and meeting these particular objectives, and we'll go through what some of those are. There are also payment adjustments that are there for people who choose not to be involved in it. But I want to talk very briefly about sort of who is eligible for this. Now, obviously, there is a Medicare and a Medicaid portion of this. The Medicare portion of electronic health records incentive programs is administered by CMS, but states administer individual Medicaid programs. The eligibility that we're going to go into very briefly here was defined in statute. That means that Congress actually decided this. We often get the question about, why can't CMS make this person eligible to participate? Why can't we often hear long-term care facilities be eligible to participate? We don't decide that eligibility. It was decided by Congress. There is a stipulation that eligible professionals, and we'll run through what those are, can participate and receive incentives, and hospitals can participate and receive incentives. But eligible professionals who are considered hospital-based, who are working primarily within a hospital environment, are not eligible to receive the incentive. And the thinking for this is really that hospitals are receiving the incentives for those electronic health records already. The way we define hospital-based is that 90% or more of your covered professional services are in an inpatient or an emergency room. So this is sort of the Venn diagram, and if you actually made this representational, that middle portion would be the largest portion by far because there's a lot of overlap between Medicare and Medicaid. As an eligible professional, you have to choose whether to participate in one program or the other. On the Medicaid side, the incentives are slightly higher, but you do have to meet a particular patient volume requirement to participate in it. Primarily, it is physicians who can be eligible for both programs. You can see doctors of medicine and osteopathy, doctors of dental medicine or surgery are the ones who are eligible for both. There are also doctors of optometry, podiatric medicine, chiropractors who are eligible on just the Medicare side. Medicaid does expand it a little bit, so there are nurse practitioners who can participate, certified nurse midwives, and physician assistants who are in very special circumstances when they are working in a federally qualified health center or a rural health center that is led by a physician assistant. The whole concept of the EHR incentive program is organized around this concept of meaningful use. The idea is to use those certified EHRs in a way that really can impact healthcare. And we put this, the conceptual framework of meaningful use in this sort of three-stage process. If you've ever seen us do any type of an overview about the EHR incentive program, you always see our famous arrow slide because it neatly kind of illustrates the way that the program works. It is an escalator approach. You start at the bottom here in stage one and you work in successive stages up to the point where we're really going towards improving outcomes. Stage one, which is where everybody starts at, and it's the only stage of the program that has been implemented so far, is about putting an EHR in place in your practice and capturing data in a standardized format within that EHR. As we move into stage two, the beginning of which can happen as early as next year, we are focusing on more advanced clinical processes. In this case, it is really about the exchange of information. Because we have standardized information, and we have standardized the way that information can be transferred from one system to the next, we are now able to move on to actually moving that information across different settings of care so that we can really focus on continuity of care for the patient. And that's really what stage two centers around. And ultimately, stage three, which we have not put the requirements out about, right now our Federal Advisory Committee is considering that, will look at improving outcomes, how we can take standardized data and how we can take exchanging that data and making it available across a variety of care settings to actually improve patient health and patient outcomes. So everybody starts at stage one, and this is the big misconception that I want to clear up right at the beginning. If you have not started yet, you do not start next year at stage two. Everybody starts on the lowest step. So you're always going to start at stage one. Your first year of meaningful use is always a 90-day, and then you move up progressively from there. So your next would be stage 1 requirements for a year, then you move on to 2 years at stage 1, and then you would move on to stage 3 and so on. The whole framework of meaningful use is organized around these core and menu objectives. These are all objectives that you either have to achieve or you have to be able to have an exclusion for because they don't necessarily apply to your individual workflow. The core objectives are objectives that everybody has to meet or have an exclusion for. There are menu objectives, and you choose out of that menu objectives the 5 that would be most applicable to your workflow. So you're aiming to do about 20 total objectives through this. These are the core objectives. Some of them are things that focus on patient safety, like having a drug and drug allergy interaction checks enabled. There's one for clinical decision support in here. There are others that focus on recording data in that structured format, so maintaining an up-to-date problem list, an active medication list, a medication allergy list. Obviously, we're going to talk about computerized physician order entry a little later on. One of the things that I want to clarify here, and we'll go into the requirements for CPOE, but there is a misconception by a lot of people. We hear this all the time. As a physician, when I use an electronic health record, all of a sudden I'm going from spending 7 minutes with a patient to spending 15 to 20 minutes because I have to enter all of this information into electronic health record. But really, there's no requirement that the EP themselves, the physician, has to enter that information at all. In fact, for all of these objectives except the computerized physician or provider order entry, there really isn't a requirement about who enters that information into an EHR or who takes a particular action at all. Anybody can really do that. The only objective that there are any requirements around who does the actual entering for the EHR is that CPOE that we're going to talk about a little bit later. These are the menu objectives. Again, you choose 5 out of these. They center around one of those objectives has to be one of these public health reporting objectives that you see at the end, reporting to an immunization registry or reporting on syndromic surveillance data to a public health agency. But otherwise, you would choose menu objectives out of these that fit your particular workflow. As we move on to stage 2, as I said, the process, the core objective structure stays the same. And you can see that we tried to make the total number of objectives that you would meet relatively the same too. So we still have that core structure, those objectives that everybody has to meet, and then we have that menu objective structure that you would actually pick from. We eliminated some of these objectives as we move into stage 2 because we've seen such consistently high scores on them. There are other objectives that have been combined. There are certain things that we have eliminated altogether, like testing exchange of information, because we're actually moving to actual use cases of exchanging information. And that's how we kept the total number of objectives roughly the same. So you will see that what we've essentially done is the things that were menu items in stage 1 become core items in stage 2. Things like incorporating lab results into your EHR, generating patient lists, providing patient education based on the information that is in your electronic health records. All of those things that you could choose from that sort of menu items in stage 1 are now things that everybody has to do. And then there are new items that move into the menu for stage 2. There are items like recording family health history, making image results accessible, including progress notes. We did introduce a new concept into stage 2 directly into the core of secure messaging. We have moved from stage 1, where we are providing patient information electronically to patients upon request, to a online portal method, and this will be incorporated into 2014 certified EHR, where patients can directly access their information and be able to download that or send it to the next provider of care. Through that same portal, there will be access to secure messaging so that a patient can send either a secure email or however else that messaging format may work directly to your practice so that they can talk about different clinical issues. There are two real focuses in stage 2 as we move forward, and one of them we sort of spoke about, but the other is patient engagement. And we introduced this new concept into stage 2 that isn't in stage 1. So those of you who have already embarked on this is going to be something new that you see when you start this next year. The idea was to get patients actually involved in their own health care and in the use of health IT to manage their own health care. So you see, we talked about this secure messaging concept, and we also talked about having patient information online. But one of the measures that we introduced was actual patient use of the health IT, and that's new. In stage 1, it's all about what you're doing in the practice. It's all about what has been recorded for that patient. In stage 2, there are small measures, small benchmarks of 5%, but actually patients accessing that information or using health IT. The other emphasis is electronic exchange. And this is really sort of the heart, the beating heart of what meaningful use is about, because this is really what holds the potential to actually make an impact on care. Being able to send patient information, test information, relevant clinical information to the next provider of care to provide continuity of care. So you'll see that this was a menu item in stage 1. It is now a core item as you move forward into stage 2, that you have to send a summary of care record for more than 50% of your transitions of care to the next provider of care. There's now also an electronic component, so 10% have to actually be submitted electronically. And then there is a requirement, and I'll explain this, that at least one of those summary of cares has to be sent to somebody who is using a different EHR vendor than you are. And the reason that we introduced this concept was to make sure that information could live beyond what we call the walled gardens. A lot of us work in organizations where it's very easy to send to a referring physician who is within your network or within your organization, but it's not easy to send information to somebody else. In many ways, that's purposeful. A vendor doesn't really have a motivation to allow information to leave their system and go to another system. We wanted to make sure that information could follow the patient, not just the system. So there is a requirement to be able to send that information outside of it. It is a requirement, obviously, not only for eligible professionals, but is a requirement for vendors to be able to make available through their certified EHR as well. There's obviously one of the things that has to be done as part of this is clinical quality measurement. It's reporting on clinical quality measures. There aren't benchmarks for these, but you use an EHR to actually calculate these. Something that was previously done by chart abstraction can now be done electronically because that patient information and that electronic clinical information is available in the EHR. For those of you who are doing it now, you can see the structure there on the left. As an EP, you're reporting on 3 out of what we call core or alternate core elements. These are things like recording height, weight, and blood pressure. Then there are 3 menu items that you would select from. I think it's a total of 38 possible clinical quality measures that would be applicable to your particular clinical practice. So if you are in endocrinology practice, there's something for measuring HbA1c levels. As we move into 2014, we've expanded that. There's now a total of 64 clinical quality measures. You would choose 9 of those. You have to select clinical quality measures that cover 3 out of the 6 national quality strategy domains. I'll explain that in a second. If all of that seems a little complicated, we tried to make it a little bit more simplistic. We have a recommended core set. So there's a recommended core set of 9 for adult populations. There's a recommended core set of 9 for pediatric populations. So you may not be familiar with this, but you're actually familiar with this. It may not be explicit to you, but this is actually the way that the Department of Health and Human Services has been organizing a lot of its quality improvement programs for quite some time. It's this national quality strategy model where we identified these 6 domains that are sort of high priority domains for what we need to do in healthcare, and they center around patient and family engagement, patient safety, care coordination, population health, efficient use of healthcare resources, and clinical effectiveness. In fact, all of those objectives that we talked about for meaningful use are actually organized by these national quality strategy domains. A lot of the clinical quality measurement programs that many of you participated previously, those quality measures are developed according to those quality strategy domains. So we've really just made this explicit as we've gone through. You don't have to put a huge amount of thought and effort into this. If you go into the website, we actually break down all of the clinical quality measures by what quality strategy domain they go into. When you submit through attestation, those of you who have actually gone through our website and do this, you won't be able to proceed unless you select quality measures from 3 out of the 6 strategy domains. So the fail-safe is built in. It seems a lot more complicated than it is, but again, there are the 9 core that you could choose from as well if you wanted to. There is absolutely no way that in 15, 20 minutes I could possibly give you an overview of this program that would make a whole lot of sense. So I realize there are a lot of moving parts to this program, and when we actually get into what the individual objectives require and the things that it requires for workflow and what those measures are, it becomes even more complicated. And I'm sure that many of you who are looking at stage 2 realize exactly that as you're trying to implement what some of that is. So please know that our website has a wealth of information. That's our website there. We have resources for both stage 1 and stage 2. If you are confused about what your personal timeline is when you do stage 2, when you would do stage 3, we actually built a widget where you can pop in what your starting date was and it will spit out your personal timeline. We have access to a variety of FAQs and trainings and webinars and a huge number of things that are on there, including our national call center. So if you actually have any issues that is specifically for the EHR incentive program, you can give them a call there. So please do visit our website. We have a lot of answers to questions there and some intro guides if you're just getting started. That's me. If you have any other questions that you cannot find there, please feel free to email me. I am always more than happy to help folks. Like I said, we know there's a lot of moving parts to this, and we definitely want to help everybody succeed because electronic health records really do hold the potential to have very significant impact on patient care.